Good afternoon, everyone. My name is Daniel McHale, Senior Vice President here at the Massachusetts Hospital Association for Healthcare Finance and Policy. I want to welcome you today. This webinar, Working with Undue Medical Debt. A few logistics before we start. If you have any questions during the webinar, please enter them into the chat feature as we are in a listen-only mode today. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2024 annual and strategic sponsors for their support in underwriting today's webinar, which is just one of the many events we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I'm pleased to introduce our speaker from Undue Medical Debt, Ruth Lande. Ruth is Vice President of Provider Relations at the nonprofit organization Undue Medical Debt. She has worked with hospitals here in Massachusetts and across the country in addressing medical debt solutions that benefit both patients as well as healthcare providers. Ruth has worked in hospitals. She has experience directly leading hospital revenue cycle teams at an academic medical center and integrated health system. She has expertise in patient access, operational transformation, and clinician alignment. She has been recognized for initiatives resulting in enhanced financial performance, high-value outcomes for physicians, administrators, patients, and employees. Now, Massachusetts has a long history of creating financial solutions to support access to care for the uninsured and underinsured, including our Health Safety Net program, which you're all familiar with. So this is an exciting opportunity to build on that creativity, both in a way that benefits patients as well as hospitals. Thank you so much for being here today, and we look forward to the discussion. I'll hand it now over to Ruth to get us started.
Great. Thank you so much. Hello to everybody who's out there listening. I'm going to go ahead and share my slides in 1 second. And let's see, here we go. Share. All right. I'm assuming that's visible, and somebody will tell me if it's not. So yeah, I really appreciate the Hospital Association helping to get the word out. We're a small organization at Undue, but we do work nationally. A lot of the amount of debt we've acquired has all been in the last few years. We've been going through sort of, crazy growth. And I think, as you can see, the topic, even the term medical debt, I mean, because I have worked in rev cycle, as was mentioned, for decades, it wasn't sort of a word that you would see constantly in the news the way that you can see it now. All right, let's see. No, oops. All right, sorry, my screen share. There we go. So often when I'm at an HFMA event or something like that, the first question that people have is a little suspiciously, all right, where does your money come from? So I always want to start with that so that people understand that. And we are philanthropically supported. That means individuals. In the first few years of our organization's history, it was a lot of faith-based organizations, a lot of churches and other faith-based organizations who supported us. Foundations, corporations, local governments now came to us. We never planned that, but starting with Cook County, Chicago. So a lot of the press you'll see is because governments have decided, hey, this is a cost-effective way to help communities by funding our acquisition of medical debt. And specifically in Massachusetts, there's a new foundation called Atrius that has given us a chunk of money because they really focused on debt relief in Eastern Massachusetts. And there's sort of a coalition that Atrius has put together of other groups that help patients. Many of those organizations I'm sure you're familiar with, because increasingly we're trying to figure out how we help patients, how we help providers, how we sort of arm everybody who's in this crazy I always put system in quotes because it's so complex that it's hard to imagine if it is a system, but process anyway. So we're working with a lot of community groups and other groups to arm together and help patients in every community. And yeah, we've hit this wild number of 14 billion so far. There's a little ticker you can see on our website. So we are small, but we have been erasing a ton of debt, 8 million families. And part of our good fortune is having gotten large sums of money from the philanthropist Mackenzie Scott. Our board is filled with public health people and other accomplished folks. And for those who are compliance focused, One of the most important things was in 2020 when we got an OIG advisory opinion to say it's fine for us to work directly with providers. There's no issue with that because we're dealing with debt that's already attempted to be collected. So it's, and the basic thing is, yes, we never collect. Sometimes I have to say that a few times. So let's, I don't know why my down arrow doesn't work as well. All right, I'm gonna do that. Okay, so who is our typical provider partner? Typically, and of course this represents most of the hospitals that are out there, nonprofit hospitals. We do work with for-profit as well, but our typical provider is a nonprofit who has never sold debt. Often I hear that, oh, we don't sell debt. And I say, that's great, right? You don't sell debt to collectors, but it's different to sell debt to Undue. And again, I think we all know most hospitals don't sue patients, don't credit report. Some of the media out there is very, acts like all hospitals are extremely aggressive, but I think we all know that that's generally not the case and have solid financial assistance. So why do providers work with us? There's a lot of reasons, but I really like this quote from the CEO of University of Chicago Health System, that it's about peace of mind, that even though a health system, you don't sue, you don't do that stuff, people are scared. They don't know that, even though I'm sure it's somewhere on a website in a policy, they often assume the worst and they avoid care. They feel very bad. So debt forgiveness really helps, especially patients who don't engage with a provider, who don't apply for financial assistance. Those are the folks who really need to hear that they're okay. Sorry, I'm having problems with this thing. I really encourage you to look at our website. We have a lot of patient stories. Patients don't need to do anything to get the benefit of debt relief from us. We send a letter and it's done. But we encourage them to share their stories because we really want to have policy changes so that we have lower deductibles and all those things that really cause medical debt. And so we post a lot of these stories, and here are a couple from Massachusetts. And I encourage you, they're really very moving. Massachusetts is a very unique place where medical debt is lower than in some places, particularly the states that have not expanded Medicaid. But it's still, it's still there. I think if you look at this study from Kaiser Family Foundation, the lowest amount is in Hawaii, which is really because of policy things. Hawaii doesn't even allow high deductible plans, just in case you were wondering. And they make sure that everybody's insured, even people working part-time. So they've really had some good policies that help both patients and providers and make sure that everybody has good insurance. And Massachusetts, through the Mass Health thing, has also done a lot. But there are still people who have insurance, who may be above that 300% mark, which so they don't get Mass Health, and they may have a provider, the employer provided insurance that has co-insurance or something like that they can't afford. So there certainly are still people, and we have worked, as was mentioned, in Massachusetts. We worked with Trinity Healthcare of New England, as well as with Haywood, which I know sort of went under, but now it's back again. I think I even saw that there were some Haywood people who were signing up. We definitely, there's medical debt, put it that way. You have bad debt, right? And in that bad debt, you'll see there's people who are low income. And this is the whole reason that so many people are coming together to deal with medical debt, because it is a social determinant of health. It is more prevalent in communities of color. So organizations that are really looking at their mission and their equity work, this really fits well in with that work. And again, I have to say, even if you haven't sued anybody or done anything aggressive, if you send out bills and patients can't pay, they remember that, it affects them. People tell us their stories, how much they feel burdened by it and feel guilty about it, and they will avoid future care. So that's the impact on their health. All right. And this, for those of you on this call who work in rev cycle like I used to for many years, this is sort of obvious, but I feel like it's good to share with the whole group that this is not something that's very easy for providers to solve. This is a systemic issue, which is the co-insurances, the deductibles, the endless denials, and prior auth issues that hospitals have to hire a zillion people for and even have clinicians involved with. People do not always apply for financial assistance. We've seen this again and again. for various reasons. They may not even open their bills because they feel so burdened. And some of the new tech that's out there in terms of presumptive eligibility certainly is helpful for finding those folks. The last hospital I worked at in Western New York, definitely we used, I think it was Experian, and we did sweep through and look for people. But you don't generally run that for your entire receivable multiple times, just because it's an expense. There's also hospitals that use propensity to pay when they really should be pulling pure income. There's a lot of discussion about that out there. And if you want to discuss it more, please feel free to throw questions in on that. But to me, the really telling statistic is this one. It's from a report you can Google from Crow, who does a lot of receivable management for hospitals around the country. They just got bought by Kodiak. But that bad debt, hospital bad debt, and just in 2018, not that long ago, the amount that was attributable to people with insurance was only 11%. So the great majority was uninsured people. And now, this is national, right? This is not a Massachusetts number, but now the majority anywhere is for people with insurance. So just another clear indicator that insurance has too many gaps in it, too much out of pocket, and it's hurting people. So our debt abolishment criteria is purely based on income. And we work with FinThrive. That's who we partner with to pull income for bad debt accounts to find out what the income of the person is. So it's up to 400% FPL, and or if the the debt is more than 5% of their income. So we don't look at assets or anything complex like that. It's purely based on income. And this is our process, because I know that process matters, because people do not have, I feel like people barely have half an hour free in their day to look at anything new. So we try to make it as easy a lift as possible. So it starts out by signing a BAA with us. Obviously, if you're going to share PHI, you need to do that. You can also sign an NDA, non-disclosure agreement, if you like. That's up to you. Whenever I mention a provider's name, like I did earlier with Trinity and with Haywood, that's because they chose to go public. There's other providers that we've worked with who choose not to, so it's all up to you. You send us a file of your bad debt, and I emphasize, please send us both hospital and physician debt if you've got employed physician groups, because it's sort of simpler from a reimbursement perspective. So you give us a dump. You can go back 7 years if you like, but it's stuff that you've tried to collect on, that you were unable to show low income and classify as charity care, so pure bad debt. What we then do with that file is we run it through with our FinThrive data and our own tool. We look at how many of those accounts will qualify for our program. So for example, you might send us a file of 100,000 accounts. We'll send you back this analysis saying of the 100,000 accounts, 90,000 of them qualify for our program. So the ones that don't qualify, we have no interest in acquiring. And then we'll show you how much we would pay for this portfolio. It's all based on age of the account. So more for more recent accounts, for like 2-year-old accounts, less for 5 or 7-year-old accounts. So that's the point. When you have our analysis in hand, when you make the decision as to whether to move ahead or not. And if you move ahead, we sign another legal document, we acquire the accounts, and we give you a detailed list so that you can post back to your system just to say a comment or code or whatever to note that these accounts have been sold. And if you want to do a communication strategy, we really encourage it. It helps people open their letters. It's also really an opportunity for you to get some extra positive mention in the press, and highlight all the other work that you do in addition to working with Undue. So we encourage it and we can support that, but in the end, it's up to you whether you want to do that or not. And if you report to any credit agencies, you have to undo that. And we send out letters. That's the patient notification. We're going to send out to you at the end of this webinar a copy of the letter we send to patients, because I think you'll want to see that. And then the last bit is, after we've done this, we will work with you and give you a even more detailed analysis of these bad debt accounts in whatever way makes sense for you. So if you're a system, you have more than one hospital, or you want to see the physician separately from the hospital accounts, whatever it is that's meaningful to you, because every hospital I know wants to figure out why they're missing low-income people, especially if you've got some fancy presumptive tool that you're paying a bunch for. You want to figure out what's going on there. So we will support you and give you all that data. So we do find the majority of bad debt accounts for any hospital anywhere, including Massachusetts, do qualify based on income. and again, I feel like this is maybe a little repetitive, but there's a lot of people who don't get caught in presumptive work, or, also we're looking at income now, not the income, say, 3 years ago. So people's income fluctuates. So there's a variety of reasons. Perhaps you have a financial assistance program that has some kind of residency, limits within your service area, and we're picking up people who are outside of that, so it could be that. And some people do have a 5% medical debt burden criteria, but usually it's more like 10 or 20%. So it could be that as well. So in terms of reimbursement implications, this is for the, if there's any folks on the call who work with cost reports, if you include Medicare fee-for-service accounts, hospital Medicare fee-for-service accounts, so not the physician ones, in the file, and you've already filed for your reimbursement, your bad debt reimbursement, your 65 cents on the dollar, then the small amount we pay you, the half a penny or whatever it is that we're paying you, or the penny, you will have to handle that as a recovery, which is a pretty routine thing for cost report folks to do. You still come out, way ahead, but you do have to handle that as a recovery. We encourage people to include all accounts, including Medicare fee-for-service, because you want the older folks in your community to also get this relief. But if you want to not include them, you can also do that. I'll address that in the next slide. And in terms of any DISH impact, all of the work we're doing, in a sense, sorry, for anybody who does not know what DISH is, just continue to be happy with your life. It's very geeky. It's DISH proportionate share. This is reimbursement that hospitals get for uncompensated care. And so there's a national pool of money in terms of Medicare. So as we work with people around the country, it does have tiny effects on the pool for the remaining hospitals, but given the amount of dollars we're talking about, it's a tiny impact. But I'm also happy to sit down with your cost report folks, and we can, and I can bring in some experts on our side too, and we can discuss that. But there's really no reason not to do this work. It's not going to be any kind of sizable negative impact to you. And again, the physician debt is always nice because you don't have those kinds of reimbursement implications. I just said a sentence that you can not include the Medicare fee-for-service if you prefer, and some people say, no, I can't do that, because you have to treat Medicare and non-Medicare the same. That is true in terms of how you handle collections. It is not true in terms of this work. So I can share some documents with you. I've got a quote here, but it is not an issue. A lot of places give us all accounts. Some people do pull out their Medicare accounts. Either one, from a compliance perspective, is completely fine. Some people say, wait a second, what about 501R for nonprofits? Would this be considered selling a debt in an extraordinary collection action? If you were selling debt to a debt collector, it could be considered one, but selling to Undue is not an extraordinary collection action. And I've got a quote here from the actual 501R regulations, but essentially, since we're not collecting, it is not an extraordinary collection action. Some people have some kind of rule, a board covenant or something prohibiting debt sales. And again, those things are written imagining selling debt to a debt collector. And this selling to us is really not what those things are written about. So there are hospitals we've worked with who have had to get board approval in order to move ahead, which is usually very quick and easy given what kind of action this is in terms of helping the community. But sometimes you do need a legal opinion. But it never hurts the financial stability of the hospital, because you're taking accounts that have what the accountants call zero book value, 100% reserved, and you're getting a small sum of money. So that's it. I just wanted to note, I've got some quotes here from some of our partners. I included a quote that I liked from the CEO of Trinity Health of New England, who really talked about this corresponding to their mission in terms of caring for the whole person. That's how we see ourselves, as really partnering with providers, using these philanthropic funds to make something happen that it doesn't solve all the problems of the world, but it's really meaningful to patients, and provides you with some extra intel. So also contact information is in there as well. All right, I'm going to stop sharing and hope that there are a ton of questions that have gotten queued up here. What have we got?
So Ruth, the first one that folks would like to know, does Undue work with home infusion companies?
We sure could. Yeah. I mean, essentially, if you bill patients, and if you've been unable to collect and therefore have bad debt, absolutely. We did some work with ambulance companies recently. That was a new thing for us. We've worked with hospitals, physicians, different kinds, government, for-profit, nonprofit. So, I mean, we wouldn't work with like plastic surgery or something. It has to be medically necessary. But aside from that, there's no restrictions.
Okay, I'm gonna punt on the first one because I'll provide some background. But could you expand on the effect and how folks deal with the Medicare bad debt? In terms of writing it off, and then now they're gonna write off the Medicare, but then now they're gonna write it off to you all. How does that get resolved?
Right. So these accounts may have already been written off, right? Submitted for reimbursement. That's that 65 cents reimbursement. So if those accounts get included, and we pay you on it, you could donate the accounts to us. I actually didn't mention that, and I should have. There are folks who will donate their accounts to us. That's what Haywood did a couple of years ago. Or you could sell the non-Medicare accounts and donate the Medicare accounts. There's a lot of options here. But essentially, to answer the question succinctly, you have to handle our payment as a recovery. So that's instead of 65 cents, you might therefore net out 64.5 cents, right? Because you would take that small amount that we paid and handle it as a recovery. The other way to say it is it's the same thing as if a Medicare beneficiary, fished out an old bill from under their seat cushions, their sofa or something, and sent you a payment 3 years later, which probably happens because everything on earth happens. You would do the same thing. You would say, okay, we'll handle that as a recovery.
Okay, and just a differential, you're saying?
Yeah.
Yeah.
Yeah, so just the amount that you got, you'd reduce that. It's a very standard thing, and we've worked with CFOs all across the country. So there's nothing untoward about it.
And then I think, the question was related. There's and we were talking about this prior to today. We have a health safety net program, and one of the aspects of that program is, besides just free care, emergency bad debt. Basically, bad debt that occurred, related to an emergency department visit can be charged to our uncompensated care pool, meeting certain rules, including it's not a co-payment or and the provider, attempted collection. I guess similarly, instead of they would have to treat that as a recovery as well.
Yeah, I mean, I think mostly there's like a special program in New York as well. There's usually somewhere it says net of recovery. And I think those are the magic 3 words. I admit I'm a rev cycle expert. I'm not an accountant, but we have a lot of documents and a lot of other people who could be consulted. And I think, it's and again, it's like somebody paying really late, same kind of thing. It's net of recovery.
Other questions folks want to enter in the chat? Here's one, Ruth. Is there an average volume or percentage of bad debt accounts or dollars that a new client may expect to see qualify for this program? So what portion?
Yeah, I don't think we've ever seen less than 80% of bad debt qualify. So it is the great majority of the bad debt that qualifies. And I think that makes sense. Just probably what the income levels are in your community. So yeah, it ranges somewhere between 80 and to 95% typically of the bad debt qualifies. Okay. I just opened chat now so I can see. So can you expand upon the difference between donating versus selling you the debt? Right. So and that's the decision you make after you send us the file and when we give you the analysis. So you're making that decision when you have a lot of data in your hand. So you could, most hospitals do sell us, or physician groups sell us the debt. That is, we're going to pay you that small amount. But some places do decide to donate instead, and rather than get payment. I'm not sure. It would be interesting. I know Haywood was one of the places that did that, and it was a small hospital. Maybe it just wasn't worth the bother of dealing with any of the other accounting. I'm really not sure the reason why. Most sell because most places could use every dollar that's out there. And although it's a small payment, if you look at your bad debt going back, 7 years, it actually adds up. Again, for the larger organizations, it's something. And you don't have to be an accountant to know something's better than nothing. But yeah, if you prefer to do the donation, if there is concern about handling some of this recovery stuff, we welcome that as well. And all it means is it's the same process. It's just that we're not wiring you funds as part of it. We're still taking ownership of the accounts. Do we work with small non-profits that become aware of medical debt? I mean, we're looking to acquire accounts. That's what we're presenting about. So we have to work with people who own the accounts, that is hospitals or physician practices or home infusion or whatever. If other folks want to support us, that perhaps you want to be a donor on the donating actual funds side. I'm not quite sure what kind of small nonprofit, but if it's a small nonprofit that's a healthcare provider, absolutely, we want to work with you. One of the things we're trying to do for those small, like FQHCs or small, behavioral health practices, often you won't have a lot of resources to even create a file. You might be using a, fairly basic billing system. So one of the things that we want to do, and for anybody who has connections, we really want to connect with a lot of, Meditech and Cerner and Athena Health. Athena Health is in Massachusetts, isn't it? But we really want to work with the folks who create the platforms, because maybe they can make standard reports that would make it easier for providers to give us. I mean, if you have a collection agency, I'll say this, it's a very similar file format, because it's essentially, you've got, who owes it, what's their name and address information, all of that. It's very similar. So we try to make it easy. Let's see. Calls that come in, yes, from patients. Right. They may well not remember, that's true. Though you'd be amazed what people remember, particularly when the debt is associated with childbirth. They send us these things saying, this kid is now, 5 years old and I had all this debt from giving birth, and boy, do they remember that. But yeah, what providers have told us is that they do not get many calls. The most typical call is one that says, I got this letter, is this for real? And then, your staff would need to say, yes, it's true, we worked with them, it's for real. So it's, if somebody does have a more in-depth question, of course, we can work together. I mean, there certainly are a handful where they say, well, what about my more recent debts? But providers don't report a lot of that. And I think when you take a look at the letter, you'll kind of see why, or read some of the comments on our website. People understand that this is a gift, that it's, they talk about, wow, nothing lucky ever happens to me. They realize that this is not the normal course of affairs. This is something special that was done, the community, the provider working together to do this. So I think people understand that this doesn't mean, all my other debts are gonna go the same way, but that it's something, it's a gift. And some people talk about wanting to pay forward and help somebody else. I think people really understand it as that kind of community support. So yeah. These are good questions.
Have there thus far, so folks keep posting your questions. I guess, Ruth, the examples you gave and cited, the quotes were from, so hospitals that wanted to do this on their own. There's also some initiatives going around the country where maybe state government has said, hospitals, you're going to participate in this program. Can you speak a little bit about that and what's going on around the country?
It's kind of wild, I have to say. We were pretty amazed at Undue, but yes, North Carolina is what I think you're referring to, has, and there's some context around North Carolina. They never expanded Medicaid. They're one of the 9 states that did not expand Medicaid. So very unlike Massachusetts, which not only expanded it, but really had done that before the ACA, right? The Massachusetts has been a real leader in this area. But so North Carolina expanded Medicaid. That gave them access to some new funds for hospitals. And they put conditions on those funds and essentially told hospitals, you can get this money, but only if you do these things, which include getting rid of all of your bad debt back to 2014 and doing some screening going forward. So I know people have said, my God, is every state going to do this? There's differing opinions on that. I'm only just giving you my opinion. I doubt that it's going to be a widespread model because again, they had some special new funds associated with Medicaid expansion, but, and I don't know about other states that have not expanded Medicaid. I think there's a lot of reasons why they're not doing that. But I think what I do see more of, which I think working with Undue will help, is Oregon too. It's not so much the getting rid of old bad debt, but it's the new mandates around screening. So a lot of states are saying, hey, you're in trouble if you go after somebody who actually had low income, who could have gotten financial assistance. And the thing is that, hospitals do their best, but the fact is there's no magic way to know everybody's income. I think that's really the problem, that legislators, it totally makes sense. They're trying to do this work and saying, come on, you got to find everybody. But it's just not, it's all the proof is in the details, right? The pudding, like how to do that, because larger hospital systems have presumptive tools, but not everybody can afford to do that. And that information is not always a perfect tool out there. So I think you see that we've been having a lot of discussions around that. So working with Undue can help you in the sense that you're missing people. Everybody's missing people. There's no reason to feel bad. But we'll give you, free of charge, obviously, you're going to get a breakdown of your bad debt so you can drill into that. And whatever your process is, whatever your community is, you can see, okay, who have I been missing in a confidential way, right? This is not going to be in the news. You can look through it. And then if you've got a tool, you might say, you go to that vendor and say, why are these accounts being missed? Or maybe there's something in your process. I've seen places where they exclude, if somebody's on a payment plan, they get excluded from this. Well, they could have a payment plan, but they also could be low income. So I think there's a lot of thought, and I think there's a lot of discussion in HFMA circles about how to do this better. And there's no secret anything, but we can provide you with valuable data on that. Okay. So we've got a question here for the debt purchase. What type of reimbursement are you offering? So you want to know how much, right? Janelle, whoever this is. So it varies based on the age of the account. So it's more for like a 1 or 2 year old account than a 7-year-old account. But what I tell people is, imagine that for the amount that qualifies, take all your bad debt. Imagine 85% of it qualifies. Imagine on average that we're paying you something like 0.007, that is like 70% of a penny. Do that math quickly and you'll get a sense of it. Again, everybody's receivable is slightly different. So it could be like a penny, it could be less than a penny. But I would say do that for a conservative estimate. And who is the right person to connect with us? So it's typically the head of Rev Cycle, whoever, director, VP of Revenue Cycle or CFO. But there are places, in fact, just speaking with a really great hospital system in Massachusetts who brought in their equity people as well as their financial people to really talk about how this could fit into a variety of their efforts. So we're happy to talk with anybody. If you've got a lead clinician person, this is something of great interest, I think, to clinicians because they're dealing with the fact that patients don't always follow their recommended care because of fear. All right.
Any more questions for Ruth?
Well, maybe everybody's munching
Okay.
down sandwiches now.
Ruth, do you have any last words before we
No,
close
I
out?
don't. But we'd really like to. Massachusetts is a great place. You clearly have less medical debt than some places, but there's still stuff out there. And we'd really love to use the funding that we've got, whether it's community funding, Atrius Foundation funding. We want to give you this money. So how often do you hear that, huh? And, I know you'd be doing it also because you want to help your patients. You want to, you really want to get insight. Maybe you want to get some positive publicity. Altogether, there's very few things that are less risky than working with us on this. And so we'd really love to hear from you and hopefully the Hospital Association can help us too if there's any other technical questions that come up or that you encounter when you go back and have discussions internally. But yeah, reach out to me, any of the people on the towards the end of the slide deck, and we'd be really happy to.
Got one more came in.
A couple more. Okay. So how have clients implemented? Does this replace collection agencies in some instances or reduce agency by 80% plus? Interesting. Everybody's got a different cycle. Often people will put us, it's after if you got an early out, you probably be doing it after that, after you've done your normal collection efforts. Yeah, you could do it before your collection agency so that you don't send any low-income people to a collection agency. Some people do it after the collection agency. I mean, we urge you to do it, before, but again, everybody has their different cycle that they put it in. Yes, there's no doubt accounts we're acquiring are not going to go as much to those other places. And in fact, I think the collection industry sees us as fine that way because they don't really want the low income accounts because they're not probably going to be able to collect much on them anyway. So in that sense, it's, works well. Yeah, and somebody's saying thank you, which I really appreciate. So yeah, I'm all set.
Yeah, so thank you, Ruth. Really appreciate your time in presenting on this, I think really exciting opportunity to build upon the innovative programs we have here to support low-income folks in Massachusetts, as well as promote health equity. So thank you all for joining. And you can scan the QR code here for future MHA programs. And with that, we can close out. So thank you all for joining. Have a wonderful day.
Thanks.